Greetings. My name is Dr. Ramesh Zacharias. I'm the President, CEO, and Medical Director of the Chronic Pain Center of Excellence for Canadian Veterans. I have a pain practice at the Michael G. DeGroote Pain Clinic at Hamilton Health Sciences. Approximately 60% of the patients I treat are veterans, and most of them not only suffer from chronic pain, but mental health issues as well. We are thrilled that you have registered for today's education session on chronic pain and mental health, two sides of the same coin. I want to thank our two speakers today, our veteran presenter, Daphne McPhee, and Dr. Don Richardson, psychiatrist at the OSI Clinic. The moderator is Luc Hébert, a 28-year CAP veteran and member of the CPCOE team. The event is co-sponsored by the CPCOE and the Atlas Institute. I would now ask Fardas Hosseini, CEO of the Atlas Institute, to share a few words. Fardas.
Thank you, Ramesh. It is an honor to co-host this event. At the Atlas Institute for Veterans and Families, our primary focus is on the mental health and well-being of Canadian Armed Forces and RCMP veterans and their families. Through our work, we know the interrelatedness of these two conditions, mental health and chronic pain, and how they can impact the life after service experiences of those who have served, and what that corresponding impact is on the family members who serve in their own way alongside. Information supports understanding, and understanding is often led when we hear the stories of persons who have that lived experience, their expertise in their own journey. It is this first person sharing which shapes our research, our resources, and all aspects of our work. It is through partnerships such as this we can be most effective. I'd like to welcome everyone today as we delve deeper into mental health and chronic pain and build that deeper understanding of the correlation.
Thank you, Dr. Zacharias and Fardas, for that welcome. On behalf of the Chronic Pain Center of Excellence for Canadian Veterans and the Atlas Institute for Veterans and Families, welcome to our spring webinar. Today, there are two streams to choose from, a French language stream and an English language stream. So we are doing simultaneously translation so we can serve both streams and all the support material has been translated. You should also be aware that the presentations and slides are best seen in full screen mode. And please note that there will be time for questions after each presentation. So once again, I'm very pleased to be facilitating this webinar. The Chronic Pain Center of Excellence is conducting research that has already provided help to veterans suffering from chronic pain, their families, and the clinicians who care for them. The Atlas Institute for Veterans and Families focuses on research, knowledge mobilization, and the implementation of best practices for the mental well-being of veterans and their families. So I'm very excited to present today's webinar entitled Chronic Pain and Mental Health, Two Sides of the Same Coin. Our first speaker today is RCMP Sergeant Retired Daphne McPhee. Daphne joined the Royal Canadian Mounted Police in Victoria, British Columbia in 1986 at the age of 23. Throughout her service, she worked with the RCMP Protective Detail, Personal Security Unit, as well as threat assessment, and primarily with INSET, that stands for Investigations in National Security. In 2015, she was working with Professional Standards Policy Section when she received a medical discharge. Daphne brings the lived experience of both an RCMP veteran and a veteran living with chronic pain and associated mental health conditions. She lives in Ottawa and is happily married to another retired member. So welcome, Daphne.
Hello, everyone. Thanks for joining me. I am very privileged to be able to speak with you today. My name is Daphne McPhee, and I am a retired sergeant from the RCMP, having retired or taken a medical discharge in 2015. I suffer from what is called post-shingles Ramsay-Hunt syndrome. In a nutshell, I'm 98% sure that stress was the cause of my shingles, which was in my ear. So that combined with my husband's, at the time, recent PTSD diagnosis, there was a lot going on in our family. I was doing almost everything at home. We had 4 children, the oldest with severe special needs. And so December 2012, I contracted this horrible, well, at first it was Bell's palsy. It's very difficult watching your face droop before your eyes in the mirror. It's very scary. And, but I waited too long, unfortunately, to have my shingles diagnosis. So the nerve damage was permanent. And it was a little devastating to hear that, because usually it takes anywhere from 6 to 9 months. However, all the nerves, several nerves in the cranium are damaged, none of which I have control over. So in March of 2015, I was faced with a medical discharge because I just couldn't function. So this unexpected turn of events in my life completely upended me. I didn't know what to do. I was unprepared for early retirement. I felt like I still had so much to do. I was struggling with the pain. I was struggling with my husband's PTSD, not knowing what to do. I was depressed, I was worried, and I was really, really angry. And for a while there, I was really at an odds as far as what to do. I couldn't see myself living with this. So accepting that you have to live with chronic pain for the rest of your life, along with my husband's PTSD, the burdens at home, it left me feeling hopeless. I had no vision. I kept worrying about the future. And I was in Winnipeg, and I didn't want to go home. I didn't want to come home. I didn't want to face anything. I was angry. I realized I just couldn't do this alone, and I needed help. So I was sinking, and I really realized that something had to change, and I realized it probably had to be me. I started therapy. I went to therapy, not just with my husband, but for myself. And I realized that I had to be all in with my therapy. So I went home. I did go home after canceling a few flights. I finally went home and focused on my marriage. I focused on my kids, to understand my husband's PTSD, to understand my own nerve pain. They needed to understand what we were going through, that we were human. But most importantly, I had to rebuild and nurture my own health. So firstly, one of the things that I had to do was let go of my incessant worries about the future. I instead embrace the present, and I still do to this day. I don't worry about things anymore. I mean, 98% of the things we worry about really don't happen anyway, do they? Right? So I stopped worrying about the future, and I live more in the present day. I take everything day by day. Secondly, my husband and I chose to support each other, myself with his PTSD and himself helping me through my Ramsay-Hunt. And so that's all part of navigating our mental and physical health. And I'm happy to say that our marriage bond has deepened. We're closer, and our marriage is stronger than it's ever been. And I'm really proud of that. I really feel I made the right decision. But you see, in that, managing pain requires a constant vigilance over my stress levels, because stress is what really exacerbates my nerve pain. After all these years, I've become much more in tune with my pain and what worsens or helps it abate. For example, wind, severe heat, severe colds, getting my blood pressure up too high, things like that. Along with that, I also incorporate positive affirmations. I tell myself, I am who I am, and that's enough. I'm okay with that. that I wake up every day with a conscious choice to pursue happiness. I look at everything as a choice. Every choice I make is to live for the present day. You know, it's not always easy because some days my pain becomes so overwhelming that I literally can't function. There's some days I have to just sit quiet. I have to stay in bed. I can't even describe it. People say, you know, they have migraines, and I really feel for them, but this is more like nerve pain. It's like hitting your funny bone, but it's in your head and it's in different places over and over again. I get hot, burning poker pains in my ears, which is the worst, really. And it's affected my short-term memory. It's affected my hearing. It's affected so many things in my life. So I have to accept whatever that day brings to me, and I just work myself through it. And it's not always easy, but I take it for what it is. I've discovered that life is really a series of choices. It's when battling depression, sadness, or extreme pain, these choices can become obscure, even overwhelming at times, but they're still choices. So I choose to move through it. But like I said, I've stopped worrying so much about the future. I focus solely on things within my control now. Sometimes I can't control my pain, and that's okay. But by doing this and practicing gratitude and forgiveness and attuning to my body's needs, along with following my therapist's guidance, of course, they've all become essential steps to managing my daily life. As I previously stated, there are days when my pain becomes unbearable. You know, during these times, it's just important that I acknowledge the pain without resistance. There's nothing I can do anyway. I refrain from fighting it with the understanding that I can't win every battle, and I succumb to it, and I do what I have to do to make it through the day. You know, the paradox of recovery or living through pain, I found it lies in surrendering to it, not giving up, but accepting the aspects beyond my control has proven to be transformative in my own journey dealing with chronic pain. And I know I can say that's not always easy for everybody else, but pain is a deeply personal experience. If you think about it, it's tangible in nature. Actually, it's intangible in nature, I should say, because it makes it challenging for others to understand and address because they can't see it. Now, that in itself, that complexity can exacerbate mental health issues because people don't understand or they judge. And that can also lead to heightened feelings of anxiety, anger, stress, depression, because why aren't people listening to me? Why don't they understand what I'm going through? It's difficult. You know, people can feed on that, and I choose not to. Enduring pain not only takes a toll on the body, but it strains the mind. You know, I start the morning, and by the end of the day, I'm just so tired because I've been fighting pain all day. And there's mental fatigue with that. So that's in my head, but any type of pain will cause you mental fatigue. So to cope with my chronic pain, I felt that I had to transform my relationship with it, which often involves how we perceive ourselves, really, and our circumstances. I usually call it finding my new norm. That's basically what I have labeled it, finding my new norm. I really like the quote by Michael J. Fox. He's a hero. And he says, acceptance doesn't mean resignation. It means understanding that something is what it is, and there's got to be a way through it. That's pretty powerful, especially considering what he goes through every single day. I also understand that there's people out there with Ramsay Hunt that have had it a lot worse than I have had. And I try to tell myself too, that there's always somebody that's worse off than I am. That doesn't always help. But in the really dark days are the times that, you know, I have to get through the day. I'll basically tell myself anything to make it through. But adopting an attitude of acceptance like I said earlier, doesn't mean giving up, but rather acknowledging the reality of the situation and finding a way forward, finding a way through it. I believe it involves embracing the pain as part of the journey and integrating it the best way we can into our lives. I've stopped asking why me, and I've basically asked the universe, what am I learning from this? I have this for a reason, obviously. So what am I learning from this? Or how can I help others with this? But I believe that going through this process of acceptance and adaptation, I'm able to not only redefine my existence or purpose, but also find my way through, navigate through the challenges imposed by chronic pain. It's one of those things that you have to find your way through and find your own coping mechanisms. I basically have my top 10. And the first one is what I've been talking about, is accepting it for what it is. And I acknowledge its presence in my life. I can't change it. I don't like it, but I acknowledge that it's there and I try to work through it. Secondly, I try to have positive affirmations every day. I practice forgiveness. I practice gratitude. I meditate. With that comes, of course, the breathing, which stimulates the vagus nerve, which helps relax you. And that's huge. So I practice my breathing because the vagus nerve is attached to the parasympathetic nervous system and it calms me down. And that's important to get that breathing in there. And I do a lot of that with whether I'm meditating or whether I take a few seconds out of my day just to sit and practice breathing for a while to center myself. I prioritize my self-care. That's huge. I go for massages. I do reflexology. I even get facials. Anything that helps me relax, anything that can help mitigate the pain. I do whatever I feel works for me. And I am good to my body and I treat myself. And I listen to my body as well. So self-care is very important. Nobody else is going to take care of your body but you. I've also learned to channel my creative side a little more. I like channeling that because it releases endorphins. It's like exercise. It releases endorphins, which can help with the pain, but it also is a way to look another way and try to take your mind off it, which isn't always easy. There's some days that I try and I can't do it, and I accept that. Of course, I exercise, like I said, but within my physical limitations, I have to be careful. I can't run anymore. I can't raise my blood pressure too high. But if I do it right, the endorphins that are released sometimes really help mitigate the pain. I surround myself with positive people and supportive friends and family. Anybody who's negative, anybody who says, oh, well, you look fine, or, I can't see anything wrong with you. Anything that's negative, I'm done. I don't need to explain to people. It doesn't matter to me whether you believe me or not. I know what I have. I know what I'm going through. So support is very important. So I surround myself with positive people, with friends, with family, and I attend my therapy. Therapy is very important, and it helps me with my emotional challenges. It gives me that professional guidance I need, whether it's for myself or to help my husband or my children with his PTSD journey or helping them understand what we're going through. I also maintain honest and open communication with my spouse and my family, and that's very important because they're my biggest source of support. Like I said earlier, I embrace the present moment. Boy, is that ever important. And I've established very healthy boundaries. That's huge. So I do this every day. Most days, it helps me maintain my physical and mental health and navigate the complexities of my pain, and it fosters a well-being. Of course, this is what works for me. I believe that it's important to move forward, no matter how small your steps are. I try not to let my pain define me because it's part of my journey. It's my story, but it doesn't have to overshadow my resilience and strength. And the same can be for anyone. Remember, every move you make involves a choice. And I choose not to let it overcome me. I choose not to impose its limitations. I choose to be happy, and it's part of my journey. I hope this helps. Thank you.
Thank you very much for this excellent presentation, Daphne, and for this positive testimony, really. Now we are going on to questions which were submitted by our audience. So Daphne, here is the first question for you. Is there a RCMP veteran analogy that you find best explains the interplay between chronic pain and mental health? I found competent communication explanation can help.
Yes, I have to use the analogy that your brain is like the command center, or in the RCP, the ops center. You know, with your brain, it communicates to the body, of course, and it's really what tells everything else what to do between that and your heart. So if you can't think properly, for example, with PTSD, you have trouble making decisions, and then you also have chronic pain throughout your body. I would imagine it would be difficult to navigate both, because one is basically not communicating with the other. And at the beginning of a PTSD diagnosis, for example, or any kind of chronic pain, there's the realization, it's telling that command center that, okay, I've got something else that I have to deal with. I've got something else that I have to navigate through. And what's that going to mean? And like I said in my presentation, when you worry so much about the future, it becomes a little overwhelming, and it becomes bigger than you. And then all of a sudden, it's like nobody in that command center is talking to each other. Everybody's trying to figure things out without becoming a team, and in order to find a solution to the problem to move forward. And you have to realize that soldiers, police officers, especially with their workouts when they're young, and you know, with SWAT, with soldiering, with any type, they're so hard on their body that it doesn't really come out till later. And then all of a sudden you've got a PTSD diagnosis, and then they're aging and they're dealing with all this chronic pain. For police officers, a lot of it's the back, because of what we have to wear around our waist and sitting in the car so much, for example. So you've got to deal with the back, the knees, the shoulders. So many members I know have shoulder pain. So you've got that ops center telling you that you still have to go to work, and yet there's the other side of it that's saying, no, you have to relax and take care of yourself. And what's everybody going to think of you if you stop? So there's a conflict in that command center, that ops center, so to speak, on which way is the best forward. I don't know if that answers your question properly, but I look at it as like a command center, a little bit of confusion in the command center.
I definitely answer the questions. And before I ask you a second one that we just received, you mentioned something in your presentation that really, I mean, I was impressed by that statement. You said acceptance does not mean resignation. It means understanding that something is what it is, and there's got to be a way through it. Finding my new norm. Can you elaborate on that or add a few words? Because I think it's such a positive thinking.
Well, of course, because chronic pain by itself is challenging enough. And if you've got people around you that are, I'll give you an example. I did have a friend, like I said in my video, that said, well, you know, you look fine. I managed to get about 95% back from my facial paralysis, which was great. I worked very hard at that. So she would look at me and she'd say, well, you look fine, and I can't see anything wrong with you. And then it would be, for example, all about her. Or I would have a family member say, well, aren't you over that yet? not understanding that I've told them that this is a permanent condition. So those are the type of people that you have to say, okay, look, I need to cut this off. I can't surround myself with those kind of people because all they put in your head is doubt and insecurity. So moving through it involves creating boundaries, building a strong support network of people that can support you instead of doubt you. You need to advocate for yourself, because even with healthcare providers out there, you need to find one who understands, who knows what you're going through, or understands that it is PTSD or it is Ramsay Hunt, for example. And healthy boundaries is another way to work through it. So everybody, like I said at the end of my video, everybody has to find their own way forward and what works for them, but there's no way around it. It's only going through it. And you have to accept that, okay, this is what I have. I can't change it. So how do I create my life so I can live with it? And I think that's creating a new norm, is just your life has to change a little bit in order to accommodate this visitor, as I call it, who's come to stay.
Thank you, Daphne. I really like that, creating a new norm. I have another question for you, Daphne. What about being a veteran might make co-occurring mental illness and chronic pain more and or less challenging to experience and manage?
I think that's a tough one. You know, it's all in the little things. I think, if I understand your question, you're living with chronic pain. I think in all of this, it's peer support is the big thing, is finding someone like-minded, or you know, like you have the peer support groups, for example, and you can tell your doctor things, but it's in the peer support where you're talking to another member, another soldier, and in that group, somebody says, well, wait a minute, I have that too. You know, I that happened to me in Costco, or, you know, I have that therapy, or that happened to me in a restaurant, where it's something you wouldn't normally talk to your therapist about. And then that helps you realize that you're not alone. And I think that's the biggest thing, is that talking to like-minded and your people and your peers is very important, because you don't want to feel alone. You don't want to think that this is only happening to me. And that gives you some validation that, okay, I'm not going crazy, that maybe I did receive the proper diagnosis. Maybe I should go to therapy, because look, it's working for them. Maybe I can live with this. Is that answering your question okay?
Oh, I think it does. Thank you. Thank you very much. I see we're getting a lot of questions, which does not surprise me, but time is running out, so we need to move on the second presentation. But for any remaining questions in the chat or other questions sent to us, Daphne has generously agreed to answer them. So the answers to the questions will be posted on the CPCoE website. And so thank you again, Daphne, for answering those questions. And if you still have questions, please submit them to info@vcp-vdc.ca. So our next speaker is Dr. Don Richardson. Dr. Richardson is a psychiatrist professor at the Department of Psychiatry at Western University, and he is the medical director of St. Joseph's Operational Stress Injury Clinic in London. He is also the scientific director of the McDonald Franklin OSI Research Center at the Parkwood Institute. Dr. Richardson is also associate scientist with Lawson Health Research Institute, Tana Schulich Chair in Neuroscience and Mental Health at Western University, and he is also a fellow with the Canadian Institute for Military and Veteran Health. Dr. Richardson has more than 75 published articles and book chapters in peer-reviewed journals in military and veteran mental health, including risk factors for PTSD and suicidal ideation, sleep disturbances, healthcare utilization, treatment outcomes, and the impact of PTSD and quality of life. So welcome, Dr. Richardson.
Thank you so much for this opportunity to talk about a very important topic today, which is on mental health and chronic pain. And from my perspective and my clinical experience, two sides of the same coin. The purpose of the presentation is really to explore the complex relationship between chronic pain and mental health in our veteran population. And the goal eventually is, with this understanding, is to improve the treatment outcomes, but also to ultimately to enhance the quality of life of our veterans. When we're looking at the veteran population, there's specific and special considerations that we need to look at, and they can be grouped in three main areas. One is military culture and identity. The military presents as a unique culture that influences their perception of health and also help-seeking behavior. And as a result, they require tailored, culturally competent care that acknowledges their distinct experiences and values. And another area in the military context is combat experiences. Veterans they have specific experiences and exposures that they face during their military service that can have a lasting impact on their overall well-being. And it's very important to personalize the approach and also to look at the impact of combat experiences, especially in the area of mental health and in chronic pain. The other major area is transition challenges. Many veterans, especially if they are being released from the military due to a work-related injury, can experience significant challenges adapting to and moving from a military life to a civilian role. And therefore, we need to also provide additional support and targeted supports during this critical period. There's key definitions that we need to examine. One, defining chronic pain. Chronic pain generally refers to persistent and progressive pain lasting more than 3 months, and of course, significantly impacting their daily lives. When we look at the prevalence of chronic pain in our veteran population, it is extremely high. Approximately 51% of Canadians report experiencing chronic pain. And when we compare this to the general population, it's almost twice the rate. And then the top two are back problems, 45% compared to 22% in the general population, and then arthritis, 35% compared to 20%. When we're looking at and defining mental health conditions, there are some conditions that are more common in our veteran populations. Veterans frequently face mental health conditions, and the top three are post-traumatic stress disorder, depression, and anxiety, often related to their military service. And again, here, when we're looking at how common this is in our Canadian veteran population, about 24% of Canadian veterans who are released between 1998 and 2007 were diagnosed with a mental health condition such as PTSD, depression, or anxiety. And these are much higher than we would see in the general population. In terms of depression, 28% compared to 7% in the general population, anxiety 21 compared to 6, and then PTSD much higher in terms of 24% compared to 1%. To provide you with just some general kind of definitions of common mental health conditions, the top three here, and I won't go into a lot of details, post-traumatic stress disorder, a condition that can occur after exposure to actual or threatened death, sexual violation, or learning about the details of it. And they usually follow into general symptoms of re-experiencing the event, avoiding reminders of the event, changes to negative thoughts and mood, and then the arousal and reactivity symptoms, the irritability, the anger, risk-taking, hypervigilance, being easily startled, poor concentration, and insomnia are usually what drives people to seek care. Major depression, also very, very common, is persistent sadness and hopelessness, and or low mood and lack of interest or pleasure in most activities lasting more than 2 weeks. And this is more than just kind of emotional symptoms, but also physical and cognitive changes, like changes in appetite, changes in your sleep and concentration, and again, more concerning, thoughts of suicide or thoughts of death. And then generalized anxiety disorder is a disorder characterized by chronic excessive worry of at least greater than 6 months. And these worries are about general things that people would worry about but have difficulty not worrying, such as aspects of life, work, health, and social interactions. When we look at the impact of chronic pain and mental health conditions on well-being, this is where the combination has a very, very large impact. The combined effect of mental health and chronic pain leads to often social withdrawal, decreased participation in meaningful activities. There's also significant impairment with regards to functional impairment, decreased work productivity, and also challenges in their daily life. And of course, there's more to that when we look at social and economic impacts of the combined both of chronic pain and mental health conditions. Strained social relationships, increased economic burden, especially when we're looking at job loss, and then the area of increased healthcare utilization and the overall cost. It's also very important to understand comorbidity. And what we mean by comorbidity are two things occurring, and here in this case, two medical conditions occurring together. Both, for example, PTSD and chronic pain share overlapping neurobiological pathways. We know that mental health influences how pain is perceived and managed. And then PTSD symptoms like flashbacks and nightmares and hypervigilance can contribute to overall distress. And the same with chronic pain can further contribute to psychological distress. This interconnectedness can lead to a cycle of worsening of symptoms, which can exacerbate symptoms of PTSD and also mental health. And not unusual, sometimes the event that contributed to the chronic pain is the same event that contributed to the PTSD. Again, high prevalence of comorbidity observed in veterans, and this contributes to further impairment in kind of overall quality of life. So it's very, very important to understand this, especially when we're looking at treatment. When we look at comorbidity here, this just lists in both treatment-seeking veterans and also in community veteran populations, high rates of comorbidity of PTSD, major depression, and generalized anxiety in terms of chronic pain and mental health comorbidity. When we look at overall treatment, we also need to look at specific barriers that are often seen in our veteran population. Many veterans face challenges accessing specialized care for mental health and chronic pain due to limited availability of services, long wait times, and then the whole area of geographic barriers, meaning almost a third of Canadians live in rural areas, and most of these rural areas, not surprising, have challenges with accessing specialized services, and this can create a further barrier. There's also the whole area of stigma and misperception. Stigma surrounding mental health and also chronic pain can further delay veterans accessing care. Very, very important when we look at screening and assessments. I won't go into all the details of what's involved, but there are screening tools that can be easily completed either in the waiting room or self-assessment, including the primary care PTSD screen. And there's also PTSD checklists. There's also questionnaires specifically for depression, PHQ-9, the GAD-7 for generalized anxiety, audit for alcohol use disorder, and of course what we often use in the clinical setting, brief pain inventory for chronic pain. And often, because of the complex of presentation of chronic pain and mental health conditions, often involves a multidisciplinary evaluation. So when we're looking at the basic principles of treatments, this is something that I often mention also to patients when they're coming in. There are things that we need to do at the beginning. There are things that need to be done in the middle, and then finally things that are done near the end. So stabilization, then followed by trauma or pain focus psychotherapy, and then the whole area of rehabilitation and reintegration. Stabilization, basically the primary goal is to improve current functioning, but in the veteran population, very, very important to establish a trusting relationship. As I've mentioned before, often their injury that they're seeking care for is a work-related injury, and they might have lost trust in organizations, and therefore often the goal is to build a trusting relationship. Of course, during stabilization, providing psychoeducation, just basically indicating what you have has a name, and currently we have effective treatments in order to manage your condition, whether it's chronic pain, whether it is PTSD, depression, or anxiety. We also want to teach problem-solving techniques, strategies, and also anxiety management skills. These are skills that will be helpful when they're doing either pain management type of treatment or also trauma-focused psychotherapy. And of course, assess and treat comorbidities, managing the acute symptoms, whether they are specifically related to pain or suicidality, sleep problems, extreme irritability, sometimes psychotic symptoms, and of course here, getting a proper assessment and management of chronic pain. There's pharmacological management. When we're looking at medication for PTSD, SSRIs and SNRIs and are generally first line medications, and they're medications that are antidepressants that are also helpful for generalized anxiety and for depression, mood stabilizers, and of course there are medications like prazosin that can decrease the frequency and severity of nightmares. And in terms for medication for chronic pain, there are lots of medications that have been used for pain, including the NSAIDs, acetaminophen, certain anticonvulsants, and then cautious use of opioid medications. But what is clear is that often, as we've mentioned before, two sides of the same coin. There are medications that are used in mental health that are also helpful for chronic pain. Some of these are the dual-acting antidepressants, but there's also evidence that there's other medications in terms of anticonvulsants that have also been shown to be helpful for both. When we're looking at psychotherapies, there are specific trauma-focused psychotherapies that have been used, including prolonged exposure, EMDR, and also cognitive processing therapy. These are all time-limited psychotherapies that are evidence-based to help with symptoms of PTSD. There's also specific psychotherapies for depression. And there are also psychotherapies that have been developed specifically for chronic pain, such as cognitive behavioral therapy for chronic pain, with a focus on exercise, pacing, relaxation training, cognitive restructuring, and behavioral activation. And of course, a lot of research on acceptance and commitment therapy for chronic pain. The benefit is that both of these types of psychotherapies can be used also for symptoms of depression, generalized anxiety, and for PTSD. There's kind of these alternative or emerging therapies that have been used that are mostly in the research stage. Here I've listed rTMS, which is indicated for depression, but there are some studies in its benefit for PTSD, and there's some evidence for its benefit for chronic pain. Ketamine is also the S version, or the S-ketamine is indicated for major depressive disorder, and our center did a recent meta-analysis showing ketamine benefiting veterans with both mental health conditions and chronic pain. And then stellate ganglion block has also been used for chronic pain, and there are some promising kind of results and treatments in its benefit for PTSD. Remember that this type of work cannot be done alone, often needing to engage family members, peer support, community providers, and also in the area of vocational rehabilitation. And also finally, in terms of treatment, making sure that people and patients are aware of the signs and symptoms of relapse and developing a secure plan. Also, very, very important to engage social support. We know the benefits of peer support in the veteran space. So in general, the key message is that PTSD and chronic pain are complex and often coexist. High comorbidity, especially depression and anxiety, very important to focus on stabilization and to assess change using validated scales and always remain hopeful that treatment works. And I'll leave you here with some resources that are available both online for patients and veterans and for clinicians. Thank you.
Thank you, Dr. Richardson. This was a very relevant and enlightening presentation, and certainly one that holds out hope in view of the effectiveness of certain treatment. So we'll now be moving on to our question period. Some questions submitted by the audience. So here's the first question we received for you, Don. I understand that the two conditions of pain and mental health can be a chicken egg scenario. Do you primarily recommend treating pain or mental health first? And I guess that's a question that could also be addressed to Veteran Affairs Canada.
Yeah, thank you so much. I think that's really a good question. And the challenge might be sometimes as a clinician is who the person ends up seeing first. And it could be that if they're seeing a pain specialist, they might target the chronic pain first, or if they end up seeing a psychiatrist like myself, we might be focusing more on the mental health conditions. But ideally, and that's what the research is showing, is really they should be targeted at the same time, and also being so mindful, especially coming after a presentation that Daphne presented, is really making sure that the patient or the veteran is engaged in that decision, so it doesn't become a priority for the clinician, but actually it's a shared decision making to say what is your priority, so that we can work through kind of a plan that would work well for others, and to see which area is a priority for both the veteran, and then of course what resources are available might also help to determine what kind of where to start.
Thank you, Don. One of the key messages of your presentation was to remain hopeful because treatment work, but this implies having access to treatments. So considering the lack of access to providers for the veterans and the fact that many veterans live in rural areas, could the use of telemedicine to treat chronic pain and comorbid mental health problems be useful? Would this be an acceptable alternative, or is it too risky, not appropriate?
That is a really good question, and I think what we have learned from the pandemic, and even if I look at my clinical practice, prior to the pandemic, I believe that all patients needed to be seen in person, and it was really kind of a rare occurrence that I would be seeing people virtually, even though that it was available, at least in Ontario, for example, the OTN or Ontario Telemedicine Network. But what we found is that with the pandemic, it really forced innovation in healthcare and really brought the treatment to the person's home. And some of the more emerging research is showing that the results for, at least on the mental health side, is that for most people, they can respond as well to virtual care, which really opened up a lot of treatments into the rural areas, and especially for the psychotherapy. However, if somebody's needing an injection or needing something, then we have to ensure that the resources are there so that patients can get the care that they need, even if it's at a rural area.
Thank you, Don. Another one for you. With pain education, how are you able to manage avoiding the patients feeling blamed for lack of coping or feeling pain is put off as being all in the head?
Okay, I love that question. And I mean, to start off, I'm not a pain specialist. However, a lot of kind of on my clinical side, as not surprise, a lot of veterans who are seeking mental health care have chronic pain. And I think it's really addressing that. And I think that's part of that was highlighted before is the military RCMP or veteran culture is seeing themselves as weak, whether they have chronic pain or whether it's a mental health condition, and bringing that out in the, I would say, in the talking therapy, and really using some of the skills that that Daphne really highlighted is accepting more kind of in the accepting commitment therapy line, is accepting that this is part of your new kind of your new normal or your new reality. But it doesn't mean, as she indicated, that you need to surrender to these symptoms, because a lot of the symptoms can be managed, whether it's a combination of talking therapy or medication, but that is to really challenge some of those negative thoughts. And sometimes it's working through to not necessarily having a positive thought, but maybe having a neutral thought to say, this is how it is right now, but like a wave, it will pass, and that you will get kind of a lesser of symptoms.
Thank you, Don. I have another question for you, but before that, if you allow me, I have a question for you, Daphne. I think it's a good one. Do you have any tips dealing with short-term memory loss around family and friends?
Sticky notes. That's a tough one because I've had to rely on little cue cards, putting notes in my phone. Yeah, and I'm still a little old school where I like to write things down rather than electronic. So I keep journals, I keep notes in my phone, I have sticky notes, and I don't beat myself up when I forget something, because there are times when I think, oh no, or I've booked two specific things at the same time because I forgot to put one in my phone. So I think it's important that as soon as you, for example, get an appointment or somebody tells you something and it's something you need to remember, that you write it down. There's so many times at the beginning where I would pull a phone number out of my purse and I would think, who does this belong to? And because somebody would give me their number and I wouldn't put their name on it, for example. So it's just important to keep the information and make sure that you know who you're getting it from. But I always have a pad of paper in my purse now so I can write things down. I think that's the best way to, yeah. I'm not lying when I say sticky notes because they do work.
Yeah, and please don't beat yourself because you forget something.
Yes, that's important. You can't, it's sometimes it's out of your control. And sometimes it's the universe telling you that you weren't meant to go there anyway. So you have to think, did I learn something from this? I'm always thinking, what have I learned from this? Rather than why did this happen to me? That's the attitude that I take it.
The positive attitude that
Yeah.
you have.
Can I add just a few things about
Of
that?
course, go ahead, Don.
Yes. And thank you, Daphne. And I think it also is a good reminder for myself, service providers, and clinicians to be mindful of instructions or the amount of detail we might be giving to our patients, to our clients, because they might not have a piece of paper right on hand, and to really keep it clear. And sometimes we have to learn to say, okay, I'll send this to you later, or what did I actually share with you? What do you remember? Or one of the benefits from your previous question you've asked is that with virtual care, often I try to invite is there anybody else there in the home, your spouse, a family member, where we, if they're comfortable, reviewing some of the kind of instructions or changes so that it can be clear. So we're not kind of giving long list of things that somebody might not feel comfortable yet, kind of saying, you know, I'm not going to remember all of those instructions you're providing.
That's true. And the thing is too, I know that when my husband was first diagnosed with PTSD, when he was given documents that he had to read through, it was too much. You know, even just having to fill out that back application to get, you know, what you deserve, there's a lot to that, and having not just to write your statement, but filling out the forms. You know, there's a lot there and a lot of the fine print gets missed. So in that, I think it's your instructions have to be clear, concise, especially at the beginning, and simple.
Yeah, and simple. Very good point. Don, we have time for a very last question, short answer. It's a bit more technical about intervention. How helpful have you found EMDR and somatic experiencing therapy for patients with PTSD and chronic pain?
Very, very good question. And I don't have the data for EMDR specifically. When we looked at
for people who don't know what is EMDR, it's
eye movement
eye movement.
desensitization reprocessing therapy.
Yeah.
It's one of the indicated psychotherapies for trauma-focused therapy for PTSD. And when they're looking at comparing it to prolonged exposure or cognitive processing therapy, they're all about equivalent in terms of how effective they are in decreasing symptoms of PTSD. The challenge we have is that how do we best match a patient or a client to a specific treatment? And that's where we need to engage people to show them what is different and which one they might feel most comfortable pursuing. Specifically regarding some of these, like the somatoform treatments for chronic pain, that's something I love these questions because it gets me to think about, okay, I need to look at that, putting on my researcher's hat. However, some of the websites I've provided, and also looking at the website at Atlas and the chronic pain website, often they will be posting some of the kind of the latest research that is up there. But that's something I'll have to look at in terms of its efficacy compared to other treatments.
Yeah, good point. I know that there are many questions being addressed to again to Dr. Richardson and Daphne, but again, for any remaining questions in the chat or other questions sent to us, we will try to answer them all. And the questions and answers will be posted on the CPCOE website. So the Chronic Pain Center of Excellence for Canadian Veterans and the Atlas Institute for Veterans and Families aim to bring hope to all veterans living with chronic pain and mental health conditions in their families. I remind you that a recording of this and all our sessions will be available on our website, and any questions you might have can also be asked through our site. Please do not hesitate to contact us for any information you may require. We would also be happy to get your feedback on these sessions. Do you find them useful from a veteran's perspective, or from a clinician perspective, or even from a case manager's perspective? And if you have any comments or specific topics you'd like to hear about, please let us know. So this concludes our Spring 2024 webinar series. We hope you will be with us this fall for more education. Please subscribe to our mailing list to keep the most up to date. And on behalf of both the Atlas Institute for Veterans and Families and the Chronic Pain Center of Excellence of Canadian Veterans, thank you so much for being with us today. So, au plaisir de vous retrouver bientôt. Thanks.